Good morning, everybody. I think it's 11 o'clock, and welcome to our second session of our Suicide Safer Care series that we're hosting in conjunction with the Association of Clinicians for the Underserved. Glad you guys are all here for our considerations for health center leaders. I am Cindy McDannold. I'm the Behavioral Health Program Manager at the Missouri Primary Care Association. And at this time, I'm going to turn it over to Rick Brown from ACU to tell us a little more about today's session.
Absolutely. Thank you so much, Cindy. And again, we're so glad to be able to partner with you on this. My name is Rick Brown, and I'm the Associate Director of Communications and Membership at ACU. I'll be your host for today's webinar. And if you have any technical issues during the presentation, please don't hesitate to reach out to my colleague, Josh Chung, via the chat. Also, just as a quick refresher, for those of you who are new to ACU, we are a transdisciplinary membership network uniting clinicians, advocates, and organizations to advance health equity for all. And we do that by supporting a robust healthcare workforce through trainings, technical assistance, and more. And we invite you to learn more about us, and including our upcoming call for abstracts for our 2024 conference at clinicians.org. Also, again, I just wanted to mention that if you're interested in more resources on suicide safer care as well, we do have a dedicated program page for this, which has a variety of fact sheets, toolkits, archived webinars, and much more. And Josh will put the link in the chat, but you can also scan the QR code as well to go there. Also, before we begin, I really just wanted to go over a few quick housekeeping items. First, we will be recording this session, and we will send you the recording and the slides within a week of the webinar. We also encourage you to ask questions via the chat or during the presentation as you think of them. Also, at the conclusion of today's training, please be sure to complete our brief evaluation. It only takes a couple of minutes, and it's very useful to help us improve the quality of our trainings. Lastly, of course, I'm honored to introduce today's speaker in part two. Dr. Virna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the COO and co-founder of Zero Overdose, as well as a member of ACU's Advisory Council. She's a national expert in suicide prevention, a faculty member for Zero Suicide, previously served for over 2 decades as a senior VP for a large FQHC network in New York. And with that, I will turn it over to Virna to start our presentation.
Well, thank you, everyone. Really glad to be here. As Rick said, we're going to spend the next hour or so talking about organizational approaches to suicide safer care. So please feel free to put messages in the chat. I do actually watch the chat as I go along, or also at the end, we'll have some time for some questions and discussion. So really excited to get a chance to talk to all of you today. And thanks for some of you who joined us yesterday. I see some names there. But hopefully today we're going to take a little bit of a different approach and really talk about organizational approaches. So when we think about what we're going to try to cover today, we're going to talk about patient care. How can we do an excellent job caring for people that are at risk for suicide? How can we care for our team members who may be at risk for suicide? And how can we be a part of our community where we're seeing ever increasing rates of suicide? So unfortunately, it's not an if you're going to have a team member or a patient die by suicide, it's a little more about when. And so what we really want to encourage you is to start to think about what you might do before you have an incident, and really think about both staff and patient suicides. One of the things that you can think about doing, and we'll talk a little bit more as we go through, is folding into your crisis response. So I remember when I worked in a FQHC in New York City, we had to do this thing called a hazardous vulnerability assessment. And we would spend time and we would come up with all this stuff. When a tornado hits, when a subway train goes off the L train and hits one of our health centers, just because we had to fill in like 10 slots. And one of the things that we never put there was suicide. And actually now thinking about suicides as an incident and folding it into your crisis response work has been incredibly helpful for many health centers, and thinking about what you might do before you have a suicide, and also thinking it around a review as an incident, but very separate from supporting staff who might be experiencing a loss as a result of a suicide. And these reviews are not punitive. We're going to talk about it always being a learning process, and we want to make sure that we're supporting everyone. So really getting a chance to think about what some of those steps are as we move forward, because one of the things we know is we're going to lose a lot of people to suicide this year, well over 50,000. And those are just the suicides that we know about. And so really thinking about the amount of time that we spend in health centers around other chronic illnesses, it's time to start thinking about suicide and how we're tracking our patients at risk for suicide. For some of you who joined us yesterday, we talked about why is it so important to focus on health centers. Many of the people who die by suicide saw their primary care provider in the month of death. We know that there's an increase in portal usage. We know that people who are disconnected from care actually resurface into primary care the month of death. So we have a unique opportunity as health centers to be able to really identify individuals that are at risk for suicide. One of the things that I really want you to think about as we talk today is where are people falling through the cracks? So not just falling through the cracks on the patient side, but on the team member side. If you had someone on your team who was at risk for suicide, how might you know? If you have a patient that's at risk for suicide, does everybody in your system know? So one of the big ways that people often fall through the cracks is, as an example, if I'm at risk for suicide and I call and cancel an appointment, your front desk staff doesn't know that I'm at risk for suicide. They can't do anything different. On sort of the other side, thinking about, I had a health center one time, and most health centers, most providers, organizations have a policy that if you don't come in for work or you don't, no call, no show for 3 days, then you get a letter from the organization that you've abandoned your position and your employment is terminated. And so I had someone one time that actually tried to die by suicide, and got the letter that we were terminating their employment as a no call, no show. And so really thinking about some of those policies and where people might fall through the cracks, or where you might need to rethink some of the processes that you have in place. The Zero Suicide website can be really helpful for you. If you haven't been there, I would really encourage you to go. Lots of organizational information there. So we're going to kind of break things up a little bit. We're going to talk about patients first, and then we're going to transition a little bit. So it's really important to start to identify your patients at risk for suicide as a population, and to think of them as a population. If I were going to ask you how many diabetics do you have in your organization, all of you could likely answer that question and then tell me about your A1Cs and what you're doing and a registry that you have. It really is important to start thinking of your patients at risk as a population and tracking them as such. We'll talk a little bit about some ways to do that. We're going to talk about clinical pathways and having a clinical pathway. A clinical pathway is different than a workflow. A workflow kind of says who does what and when, as opposed to a pathway which says this is how we care for someone at risk for suicide. It's less about who does it and more about what needs to happen and what we think is excellent care. Oftentimes people say, well, policies, we have a policy on caring for people at risk. I would actually discourage that. And some of the better advice is to have a clinical pathway. One of the things that you might want to think about is, can you build on existing registries? Example, if you have a depression registry, can you add a column on there for people who answer yes to question 9? So one of the interesting pieces is that many organizations really find out whether or not someone is at risk for suicide because they're doing the PHQ and answering yes to question 9. So we do know that those folks are more likely to die by suicide, and that is better than not doing anything. However, one of the things we know from some of the recent literature is that it's actually not the best practice, and that you actually miss a lot of people because you're not directly asking about suicide. And if you were going to talk to some folks at NIMH, they would say you should really be asking, particularly your adolescents ages 10 and up, very specifically and very clearly about suicide when you see them. And so one of the things to really think about is how can you embed tools, and we'll talk about some options that you're absolutely asking about suicide very specifically, as opposed to just the PHQ-9, which again is better than nothing, but really misses and has been shown to not be the best in terms of really screening for suicide. You also want to start to think about part of your quality process. So if I'm doing a peer chart review and I'm reviewing a chart for someone that's at risk for suicide, do you have criteria for what a good chart looks like for follow-up, for safety planning, like you might for diabetics or asthma or some of the other chronic illnesses? And so if you don't, that's something to really think about. And also evidence-based practices. There are very clearly evidence-based practices out there that you can incorporate that are in a lot of the EMRs. And so this is pretty easy to do. And yesterday, someone actually asked me about liability. And one of the best ways, if you're concerned about liability, is to really just follow the evidence-based practices. So one of the things that is super important is to really think about what your expectations are. And how you're going to track your population in a structured data way. So the ICD-10 codes for suicide are there. They're in all of the EMRs, they're out there in the world. And so an organizational policy and process that has you put these codes on the problem list automatically makes it structured data, automatically gives you the ability to know how many people you have in your organization that are at risk. What I also used to do is I had a reason for visit. And oftentimes if someone had a suicide attempt, I would use that for the reason of visit so that I would know about attempts. And then I would do the Z codes, personal history of self-harm or suicidal behavior, personal history of non-suicidal self-harm. I would use those codes on the problem list. So it's important to really sit down and think how you're going to use the code so there's some consistency. One of the things that organizations struggle with is what classifies as an attempt. And so it's really important that you think about this. This sounds, I'm going to use the word silly, but it is actually a really sort of more complicated issue. And when I first started doing the zero suicide work in my FQHC, I was actually shocked at how broad the definition was of a suicide attempt across my providers, both primary care and behavioral health. So I had someone and they took 8 Tylenols because they wanted to never wake up again. And I had someone who took 22 Tylenol because they really wanted to take a good nap. And so it really comes down to intent, right? Did I take those Tylenol because I intended to die? And so really thinking about what classifies as an attempt so that you can give staff really clear direction about when they might be using that reason for visit and everybody's sort of on the same page. So as an example, if someone died, we had a gentleman one time and he fell from a moving truck, and his family, the people that were caring for him, all said that was a suicide. He had talked about it before. We're certain it was a suicide. That wasn't actually how the death was ruled, but we counted it as a suicide because everyone in his circle felt like that was a suicide. And so you really need to think about how you're going to classify a suicide and sort of put that across the board and put it out for people. And also make sure that people know to report it. The other piece is to really think about what some of your expectations are. So I did something one time that I thought, I have a lot of examples in my career where I thought I was brilliant and turns out I wasn't. But one of the things was to turn the banner on the electronic health record red. It was epic and it was years ago. And we thought this was such a great idea for people at risk for suicide. And so what happened is that it actually didn't change provider behavior at all. Nothing got reflected in the notes. And that was because I hadn't been clear about what the expectation was when someone was caring for someone at risk for suicide, that at a minimum in a primary care visit, we ask if they're safe. We update the problem list to put suicide risk there. we make sure they're connected. And so I hadn't done that. And so therefore it wasn't clear to people what needed to happen. So really to think about what do we expect to happen the first time we identify a patient in our pathway, and what do we expect to happen if I come back for primary care, if I come back for other services. I had someone die by suicide one time, and the last person they saw in my system was an insurance enroller. And so after that, my insurance enrollers, everyone knew that somebody was at risk for suicide, and they knew to ask them about their safety plan and to connect them with someone if they didn't have it or weren't feeling safe. So these are the kinds of things that you need to think about as you go forward. But first and foremost, you really need to think about tracking your population of patients that are at risk for suicide so that you know who they are. And it's really a quality issue, because if I don't put suicide on the problem list and someone is covering for me, they make different decisions or ask different questions if they knew that patient was at risk for suicide. And really thinking about how you're going to identify people. I know there's been quite a few studies in behavioral health where people get asked about suicide sort of in the beginning, that famous intake, right? And where patients have reported that they thought about suicide or even had suicide attempts, but never brought it up in behavioral health treatment, basically because no one asked them. And so starting to think about how often are we actually going to ask people about suicide and when. So we know that suicide is rising in the maternal population postpartum. Are we going to ask people very specifically about suicide postpartum? Are we going to ask them when they have a transition? So if we have a process in place for people coming out of the hospital and we know that really increases their risk for suicide, are we going to ask them very specifically about suicide then? And so really giving people the language to ask about suicide and knowing people that are at risk. And doing a lot of education. Like, we know that many people who die by suicide don't have a mental illness at the time of death. And so the social determinants. So if I'm caring for a patient who has a lot of social determinants, then do I know that that person could be at risk? Do I know somebody that, do I know that anxiety is a risk factor for suicide? And do I know to ask my patients who are anxious or score high on the GAD about suicide? And so really thinking about how are we going to identify people, and how often are we going to ask people, just like any screening, right? Like when we think about interpersonal violence, we don't ask people at every visit. We ask them strategically at different times. So really thinking about what that's going to look like in your organization. So thinking about how we're going to care for people at risk for suicide, one of the things to think about is it used to be that we used to flag people for suicide and they were either flagged at risk or not flagged. It was like kind of you're in or you're out. And we've learned that that's actually not a best practice for a couple of reasons. One is, just like any other chronic illness, people don't need the same thing. So, diabetics don't need the same level of care or the same type of care for every diabetic, right? Well, the same with people at risk for suicide. People have different levels of risk. So we want to make sure we've got really solid processes in place for the people who are at the most risk, and an appropriate level of support for people who are at lesser risk. That helps us to use our resources better. And it also then makes it easier for patients who say, why am I doing this every time? Why am I getting this level of care when it doesn't feel appropriate for me? So one of the things that organizations have done is, because the Columbia scale, this is one of two evidence-based tools. The Columbia scale is in most of the electronic health records. This is affectionately known as the primary care version. And so you can actually base your pathway or your responses off of the colors on this Columbia scale. So you can do something for your yellow patients, something for your orange patients, and something for your red patients where there's some intent. And so what organizations have done, and we'll share this, and I certainly know you can't see some of the details here, but this is an example of a pathway that basically says, for our red patients, we do this. We don't let it go more than 7 days. We make sure they have a set of behavioral health eyes on them. We make sure they get safety plans and Columbia scales every time we talk to them. Whereas our orange patients, we don't go more than 14 days. We make sure they have an active safety plan in place. We want to make sure for our yellow patients that they have resources available and that we're in contact with them. We have a category of people that are historical because I just actually had a birthday yesterday, so I'm older now than I was yesterday. But if I had a suicide attempt when I was 16 and I tried to die by suicide, that was many years ago. But I'm more at risk my whole life. And so we want to know that, right, in the chart. Maybe we put it on the problem list, but we resolve it and it's there so that we know about it for a consideration, but they don't actually need to be on the pathway where we're really following them and tracking their care. The other thing about doing it this way and having people that are stratified this way is we can also know if we're reducing risk. And so if I take patients who are at high risk, red, and I reduce their risk to orange, and then I reduce their risk to yellow, then we know that we're helping people get better. And so the way that it works is people will say, if you haven't had an incident or risk in the last 3 months, then you get reduced, and there's some criteria. A lot of organizations, and yes, we'll share this slide. I know that it's difficult to read. A lot of organizations will say, we're not going to reduce your risk if you've had a transition, or if you've had an event in the last 30 days or have any psychotic features. So we tried to put a guide here. We will absolutely share this, and I'm more than happy to help people talk it through. But yes, we will absolutely share this. And what a lot of organizations are doing is actually putting very specific questions on the bottom of the PHQs, particularly the one for adolescents, so that you're asking very specifically about suicide. And that's been incredibly helpful. So I mentioned that there were 2 tools that organizations should use. One is the Columbia scale that we talked about. The other is this one, which is the ASQ. I find this better for children and adolescents. To me, it's just easier to use. I also think the research is a little stronger. But actually, question 5, are you thinking of killing yourself right now, is crystal clear. We can use that, and then we kind of know what to do. I also like the guide for nursing and parents and guardians. I also think that's really helpful. Oftentimes organizations will say to me, well, we have this homegrown tool. That is a solid no. There are 2 evidence-based tools out there. There's the Columbia scale and there's the ASQ. Pick a lane and go for it. I personally pick a lane 16 and up with the Columbia scale, 15 and under with the ASQ. That's my personal lane. That's what a lot of organizations do. But either way, you need to pick one. I would strongly encourage you not to have something that is homegrown, and use what's out there that's evidence-based. Most electronic health records have a version of the Columbia scale built in. This is the Columbia scale for kids, so that you know it's there, and then you could use these colors to stratify the younger population as well. And my right-hand person, Rick, is actually putting stuff in the chat for all of you. So I really encourage you to strongly think about developing a pathway. I like to sit, so two sort of things to think about. I like to sit with the team, maybe at a staff meeting, and say, if we were going to do an excellent job caring for people at risk for suicide, what would we do? And then using that to back into a care pathway. So we would want to make sure that we ask people directly about suicide. Well, when would we want to ask them? You know, this is how often we would talk to them. So really start to think it through. And then think about tracking so that you have a way to know if the things you decide are good care, and you have a pathway, that you have a way to know that they happen. And that you have a way to know how many people are at risk in your population. So I'm going to switch gears a little bit and talk about suicide across team members. So unfortunately, we know that individuals in healthcare actually are at high risk for suicide. I've done several presentations now with ACU and AMA and a few others, and unfortunately, it hasn't been difficult to find health centers that have lost individual team members to suicide. I was in Montana recently teaching at an organization, and they talked to me, they've lost 2 staff members to suicide in as many years. And so really important to start to think about how you're caring for your team members and being suicide safer across your team members as well. You know, one of the things that is pretty shocking is that we lose a physician a day to suicide. And also thinking about medical students and residents. Part of this project with ACU is that we've gotten to go around now. We've trained over 4,000 primary care providers and their teams in about 32 states. I've kind of lost track. But I have never gone in all of those states to a medical residency program or medical school where a resident or a medical student didn't come up to me and tell me a story about someone that they've lost to suicide during their training. Not one single time. And so really important to think about medical students and burnouts. I did something when I worked for the FQHC. I did during rounds sort of an anonymous thing and just asked about suicide and suicidal thoughts. And our residency director and my medical leadership was shocked at how many residents in our own family practice residency programs had thought about suicide, attempted suicide, were actively thinking about suicide, and we never ever brought it up in our training program ever. So really important to start to think about and what that looks like almost from day one, because we know that a lot of the medical providers who die by suicide aren't getting mental health treatment, often feel like they can't reach out. And so really making sure that we're making resources available. And also thinking about how we're notifying people. The time to draft the email is now. What email would we send out to staff? How would we notify staff if we lost someone to suicide? What would that look like? And so really thinking about the email now, vetting it, who's going to send it, because one of the things that we often get are emails sent from around the country, and people saying, you know, this email just made me feel so bad. It was so inappropriate. We all know it was a suicide and leadership didn't say suicide. And so really thinking about what that looks like. And there are examples of emails that you can send on the EDC website and other places. But the worst thing you want to do is when someone dies by suicide and you need to notify people to really have to craft an email that goes out to the organization or the practice at that point. One of the things that I think we always sort of knew anecdotally, but really came to light over the past couple of years, and they really looked at it in 2019, was the high rates of suicide in nursing. And interesting, the different causes of death that are there. But when you think about nurses, female nurses, 23% more likely to die by suicide than women in the general population. That's a pretty astounding number. And so really encouraging you to think about that and to educate your team members so that they know, because clearly the suicide rates are higher in healthcare than they are across the board. We saw that increase during COVID, as we did a lot of other struggles during COVID. This was actually one of the headlines during COVID that got quite a bit of attention. So when we start to think about some organizational responses, really thinking about suicide safer care and thinking about suicide safer care across staff. One of the things that we want to do is really train our managers in how to respond. So we've done some training, and we always talk about storage statements and giving people language to respond to someone who told you that they're thinking about suicide. We want to thank them. Thank you for telling me you're thinking about suicide. Your life is very important to me. and giving managers, giving staff people some very clear responses. Works with patients, works with staff. So one of the things that you want to try to really think about is, what does someone do then when someone tells you? Oftentimes the thought is to call human resources. And I get so many calls from human resources around the country saying, what do? We don't actually know what to do. Or we had this happen. I had something one time where human resources called me in my organization, and someone had been identified as being at risk for suicide. They were a medical assistant, and they walked them to human resources. Human resources went into the director's office, called me, and I asked, well, where is this person now? Because I was going to come over and see them. And they looked, and the person had left. And so we really thought about, what do we really need to do? How can we train the team members so that they know what to do? I actually had someone put someone in a supply closet one time so that they would know where they were, and they weren't able to leave. And so that was really a training incident. One of the things to think about, if you have an employee assistance program, do they actually know how to care for individuals at risk for suicide? What is their process? What is their training? So if I called your EAP program and I said, I've really been thinking about suicide and I'm struggling and I don't know what to do, are they actually trained to manage that conversation? And really thinking about what you're going to be able to do beforehand. Again, that hazardous vulnerability assistance plan or some other, and really asking people, when our medical residents or people join, are we asking them very specifically about suicide at any point? And really letting managers know how to have the conversations, and also how to ask. I heard you say that you've been incredibly stressed out and that you wished you could just go to sleep and not wake up. I'm wondering if you're thinking about suicide, and letting managers know, ask very directly about suicide. If someone makes a statement or you overhear, ask them very clearly and very directly, maybe take them aside. And ask them, because we want to ask exactly what we want to know. Not, are you okay? You seem very stressed. We want to know very specifically about suicide. So giving managers that language and that training can be incredibly helpful for them. And often giving them a guide. So there's actually some really good guides out there. We can share them, and we'll certainly share this slide. But letting managers know, here are some of the warning signs for suicide. Here's what you can do or say. Here's what we expect to happen. Here's some resources that we have internally. Our EAP program is specifically trained. We have a dedicated behavioral health person. So I work with one organization, and they actually had a subject matter person who was specially trained in behavioral health, who actually, they were the person that saw employees who might be at risk for suicide and then made sure that they were connected. So really making sure that you've got some systems and some processes in place, because you definitely want to act quickly. And you also want to think about some of your other processes. So I oftentimes, I mentioned what I talked about earlier with the no call, no show, and saying, well, let's make sure that someone's okay before we send them a letter terminating their employment, right? And really thinking about what that looks like. So a couple of things that organizations have done right from the beginning, right, very specifically, and onboarding, is letting them know what mental health resources are available and almost giving them an FAQ. So when we hire individuals, particularly individuals, like providers, people that are maybe concerned about their ability to move up in an organization, they want to know. This comes up a lot with health centers that are self-insured. I get questions a lot. Well, are they going to see my records because we're self-insured, right? Do they have access to them? So letting people know that they don't have access to them. And of course, if individuals get care in your organization, you've got some systems and processes in place for that. Oftentimes people are concerned about a diagnosis and it's going to hinder their chances, like any other diagnoses. And actually, Rick can send you the link. We did a really nice webinar with a woman who was an expert in professional appointment, and she talked about the importance of changing the professional appointment documentation so that it doesn't restrict and isn't punitive for individuals who have had a history of suicide or suicidal thoughts. It's important to share the cost. So for a lot of our staff, they live paycheck to paycheck. And so how much does behavioral health services cost in our health plan? What does it look like? And if I can't afford them, what are some other resources? Will anyone know if I use the employee assistance services, right? Does anyone get a record of that? And also a little information on counseling or treatment. What should I expect if I call someone and tell them I'm thinking about suicide? What does it look like? I've never been in counseling before. I've never talked to anyone about suicide. And so oftentimes it's really nice to be able to have an FAQ document and to talk about some of these things right when somebody comes into the organization. So a couple of things to think about in terms of trainings. One of the things that we don't want to do is sort of these one and done types of training. So people say, we're going to train people and then, we're going to have people trained on suicide care. And that really isn't optimal unless you really do some things to be able to support. You start tracking your population, you build it into your quality, you build it into trainings. And also think about, we've talked, maybe your current providers sat in yesterday and learned how to care for people at risk for suicide. But what happens to new providers? If I join your organization next week, how am I going to know how to care for somebody at risk for suicide? And also thinking about very specific trainings for jobs. So I would have to say I haven't learned very many things from the Joint Commission reviews, but I did learn one thing one time. And they gave me a ding, and it made me particularly bitter because I had gone quite a few visits without any dings. And one of the things that they dinged me on, that's a professional term, ding, was that my compliance trainings, I did like a broad training on compliance, fraud, waste, and abuse across the organization. And they said, well, it doesn't look the same for everybody, that you need to have very job specific trainings for fraud, waste, and abuse. And they weren't wrong. And I started to think about it in terms of suicide safer care to say, well, what actually do my billing people need to know? Do my insurance enrollers? Do my primary care providers? And so I did a training recently, and there were a lot of billing people on the call, and the billing manager, I think, was not super happy to begin with. And then during the training, the billing people were saying, someone said this to me and someone said this, and people make suicidal statements all the time when we're talking to them. And so it was really important to be able to give them some training that was very specific to their role and what they might hear. I had a maintenance person one time call me and found a note in the garbage can and wanted to make sure that it had gotten seen, right? So and then pulling very specific examples. So I pulled those examples and used them in future trainings for those teams and departments so that they would say, oh, this is why I have to know this. This is why it's relevant for me. And also thinking about doing trainings that not only use real world examples, but give them the opportunity to say, what could I do differently? So I did something one time with the VA, and we all sat around, everybody in the whole VA organization, and the CEO, who was wonderful, talked about their suicide safer care work and said, what could everybody do differently to take better care of someone at risk for suicide? And it was fascinating to hear the ideas that people came up with. There was a van driver who said, I'm going to make sure that everybody who gets in my van has the veteran's suicide number built into their phone. And so ask your people, what do you think you might be able to do differently to care for people at risk for suicide? Also, we've learned a lot about training. If you're thinking about training around suicide safer care, oftentimes we bring people into the organization, we give them, an HR training, and, the best thing that happens is you get a good lunch. And then the next day you learn how to use the electronic health record. And then based on sort of where you go and what happens, you may or may not learn about how to care for someone at risk for suicide. And so what organizations have started to do is 2 or 3 weeks in, actually take direct care providers and say, this is how we care for people at risk for suicide. This is how we do a Columbia scale. This is how we do some safety planning. This is how we document in the EMR. This is what we look for in a chart review. And that way it really allows them to conceptualize it all in one place. I know what the expectations are. I know how to do it, and I know how to document it. So really thinking about what that looks like. And also, if you're going to do some training, how are you going to know it's successful? So if you train your primary care providers, train your behavioral health providers, what changes? Are you seeing suicide on the problem list? Are people getting Columbia scales and safety plans? And what does that look like? When we think about training, one of the best ways to do it is to list all of the job titles. And then I like to put them in 3 buckets. So you have bucket A, which is these are the folks who are direct care clinicians. And they might learn how to do safety planning, Columbia scales, like we may have a battery of trainings for them that they get one time during employment and then refreshers each year. And then we have folks like insurance enrollers and outreach staff and, front desk staff, billing, and they get some training, a certain level of training. And then we have sort of back office, non-patient care facing, and they might get Safe Talk or some training one time during employment. And so if you divide it out like that, and then you can operationalize what training looks like in your organization, and then you can just put it in whatever infrastructure you currently have to be able to track training. And then how does it get reinforced, right? So I did a training one time where I trained all the behavioral health leaders, and then I didn't change my supervision to really reinforce it. And so I wound up having to redo it. And so what does that actually look like? And a suicide safer care organizational approach is really training, on the bottom and having leadership support on the top and coming at it from both ends. It's not a project or a program. I wouldn't want you to leave this webinar and say, okay, now we have this, project, and we're going to do this suicide safer care. Projects have beginning, middle, and ends. I always say, unless it's like, my kitchen and my husband, but like normally they have beginning, middle, and ends, right? And that's not what this is. This is ongoing. We don't have a diabetes project, right? We are continually evolving in how we care for people with diabetes. Think about the population of people who are at risk for suicide very much the same. Build into your quality improvement, your safety, your emergency prep, your tech, performance evaluations, bake it into all of those processes and have some ways to measure. I need to know if someone comes into my system and they're at risk for suicide and they don't have a safety plan in place, that's not cool. I need to know about it. I need to train that person to make sure that they've got a safety plan. Also, it's helpful to have a champion in this work. And so there's 2 kinds of champions. There's the volunteered and the voluntold. And oftentimes when I go and do zero suicide work in organizations, I get someone and they say, well, I'm the champion, and oftentimes it's the person that somebody thinks has some bandwidth. And generally that's not necessarily the person who would have picked to be the champion. And so I oftentimes will just let the work be, and champions rise. And so once people rise and they show an interest in the work, then have them be the champions. So maybe hold off a little bit. And then let everybody know what the expectation is, that we're going to start caring for people at risk for suicide in a very organized way. And this is what the expectations are. And this is how we're going to think about care and what it looks like. And really creating a culture of wellness. How can I bring this up in supervision and feel comfortable doing this? That I find out about suicide safer care right when I come into the organization. That we put suicide information up on bulletin boards and once in a while on a daily computer message. That I get the lifeline information in 988 when I come in to onboard. right? That it's part of my benefit package that really encourages wellness. We talk about suicide in the organization. If we're worried about someone, we ask them directly about suicide. We're really clear in making sure that this is an organization, whether you're a patient or a team member or someone in the community, this is an organization where we talk about suicide. Offer some educational opportunities for people so that they have the ability to advance their skill. Really thinking about when you might have to intervene. A lot of times, the way that team members identify as being at risk for suicide, they'll make a suicidal statement at work that someone will hear it. We had a nurse practitioner die by suicide recently in an organization. And she had made statements like, I can't go through another breakup. Like, I'm not going to survive this breakup. And she had made some suicidal statements, had given away some of the things from her office. I've had a lot of times where people have come to managers and said, listen, I'm really worried about so-and-so. They posted a suicidal statement or thought on Facebook or some other social media. Or sometimes someone will call and say, listen, I'm really worried about someone. Did they show up for work, right? Are they there? So really talk about these kinds of situations. What would we do if we saw a team member post something on social media about suicide? What would we do? So are we concerned that we shouldn't have been on Facebook during office hours? Wouldn't we tell someone because of that? And so really practicing and having some of those conversations. So I wanted to make sure we left a couple minutes for some thoughts and comments. We will absolutely share, because I know there were some slides that unfortunately are a little smaller. It's just a lot to pack into a slide. And so please feel free, unmute, you can ask questions, or feel free to put them in the chat. If you're feeling particularly shy, you can send them to me directly. So two really great questions to me privately. What are some thoughts on implementing some of these if your organization is not necessarily on board? I think one of the things that's helpful is to create or to get is a data sheet. So in other words, here's information on how many people are dying by suicide. Here's what it is in our community. Here's what it is in our practice. Here's how many physicians and nurses die by suicide. Here's some recommendations or experiences from other health centers, and then share that information sheet. Or also, have the ability for someone to come in and maybe talk to leadership is incredibly helpful. And I also think you can get support from your PCA, who, when they do hazardous vulnerability trainings or organizational or team trainings, can actually support some of these activities as well. The other one was around liability, and what do we do if someone says that they're thinking about suicide and using medications and they have access to medications at work. This actually happens quite frequently, and it's important to let individuals know, and it's important to talk about with managers. So if I'm a nurse manager and I have someone who's at risk for suicide with medications, then we need to have a safety plan at work to keep them safe from the medications. It may mean adjusting their duty. It may mean really having some conversations with them. But that actually happens often, and I would encourage you to actually use that as a scenario to problem solve. What would you do around that? Those are two great questions. Any other questions, comments? I don't know, Cindy, if there's any thoughts from the PSyD in terms of supporting some of this information.
I just put in the chat, that was a very timely question about statistics. I just got updated statistics on Missouri yesterday afternoon. And so it's put into an infographic then that you can share. So I will get that sent out this afternoon to all the health centers.
And what did it look like? Because I know Missouri was doing fairly well for, I just put you on the spot. I'm sorry.
That's okay. I can find it really quickly. Well, I mean, there's some improvement, but we're still higher. You know, our average is still higher than the national average. So let's see. I'm going to look it up right now.
And a lot of those are patients that you're seeing, patients and team members in primary care.
Yeah. Let's see. 1,200 individuals died by suicide in 2022. Missouri. The suicide rates are higher. I think some people know this, but I think sometimes it gets lost. Suicide rates are higher in rural areas than urban. Obviously, there's more total numbers in urban areas because there's more people, but the rates are higher. We are the 19th highest suicide rate in the nation. So that's an improvement. I think we were like 13th a few years ago.
Yeah.
Second leading cause of death for Missourians age 18 to 34. Third leading cause of death for ages 10 to 17. So I'll get this sent out this afternoon so that you can see this.
Yeah, great. Well, thank you for sharing that. Very timely. And for the person who sent me, maybe that's an infographic that you leave in some leadership mailboxes, or send out to the organization.
And then there's some, you'll see on here where the source is, so you can always look. CDC always has information, the Veterans Administration, and other organizations.
Yeah, they always have great data.
Oh, 19th highest in the nation for Missouri. These are Missouri statistics. I think somebody put that in the chat.
Yeah, unfortunately, if organizations, it's hard to really think about this. And unfortunately, I hear from so many health centers, this wasn't on the radar until it was. And, that's incredibly unfortunate.
And I will say, as a caveat to data, if you're looking for community specific, it is sometimes hard to get community specific data for things like this due to the numbers. If they're very small numbers, if you're in a very sparsely populated area, because the data will get suppressed, so it's not identifiable. So it is sometimes hard to drill it down. And it's also, this is just data that's not well recorded. Dr. Little said earlier, suicides that we know of. Many deaths we don't really know how many, but there are many deaths that do not get recorded as suicide that were a suicide.
Yeah, they actually think it's about 25% higher. Yeah, across the board. I actually kind of think that's low, just, knowing, some of the information. But even if you just went with that, I mean, that's a pretty staggering number.
But definitely, if you're in Missouri, please feel free to reach out if you're looking for ways to connect with your leadership or some thoughts. I'd be happy to help with that as well.
And we are going to have some office hours and some informational time for people as well. So we can certainly, feel free to join those. And we can talk about best practices. We can talk about, pathways, answer any specific questions. Well, wonderful. I really appreciate everyone's time and attention. Thank you so much for the questions and the discussion during. We'll make sure these get shared out. And as always, I appreciate your time.
Thank you, everyone.
Thank you.